This is part 3 of 4 in understanding the atrial rhythms. So let's look at a short animation of SVT, and we'll talk more about that in just a moment. In SVT, it encompasses all fast or tachy dysrhythmias in which the heart rate is greater than 100 beats per minute. This applies to any tachycardic rhythm originates above the ventricle within the atria. Paroxysmal refers to sudden onset or cessation of the SVT. This occurs when rapid heart or rapid atrial ectopic focus overrides the SA node and becomes the heart's primary pacemaker. It can resemble a rapid sinus tachycardia. Sinus tachycardia seldom exceeds 160 to 170 beats per minute in the high range, although sometimes that it can. So as we're going through, we're looking here and we see what is the rate. Well, the atrial rate and the ventricular rate typically are going to be the same, so it'll be fast, generally very fast, 150 to 250 beats per minute. The rhythm is almost always regular, primarily because you still have the same pacemaking site that is functioning. Looking for P waves before each QRS, and are they upright and uniform? Generally, it's going to be tough to see them because the rate is going to be so fast, they're going to be buried within the QRS. So you may see the QRS, but you won't see the P waves. Therefore, we're not going to have a PR interval. Do all the QRS complexes look normal? Do they look alike? Yes, generally they're going to be within normal width and they're not going to look bizarre. So let's take a look at a couple of rhythms here. Let's look at the top rhythm. If you count out your QRSs, this is a 6-second strip, you'll see that the heart rate is 250 beats per minute. Measuring out the rhythm, you'll see that it is regular. As you look in here, you can see that there are no P waves. This is not a P wave. This is actually part of the T wave from the repolarization. So, as I said earlier, the P wave is buried within the QRS, so you're not going to see it. Therefore, there is no PR interval. The QRS, if we measure it out, is 0.04 seconds. Therefore, the rhythm is considered a supraventricular tachycardia, or a tachycardia that originates above the ventricles. So look at the bottom strip. Heart rate is 170 if we measure it out, a 6-second strip. The rhythm is regular. There are, once again, no P waves, although if you look really closely here, you might be able to see a tiny P wave that comes up every now and then. So that would be debatable, but we could make an argument for it. It disappears completely over in this complex right there. Therefore, because we don't have a PR interval, we can't measure it. The QRS complex, if we measure it out, is 0.04 seconds. And once again, this would be considered supraventricular tachycardia, or SVT. Some of the causes can be overexertion, stress, hypoxia, excessive use of stimulants, hypokalemia, or a low potassium, and arteriosclerotic heart disease. Treatment is vagal maneuvers. The stimulation of the vagus nerve releases acetylcholine, which results in the slowing of the heart rate. For your patient to do vagal maneuvers, we simply have them bear down, cough, squat, or do carotid sinus massage. Drug therapy includes drugs such as adenosine or synchronized cardioversion if your patient is unstable. Wolff-Parkinson-White syndrome is characterized by 2 AV conduction pathways. It's identified by the delta wave as seen on the EKG, as you can see here. Rather than this being rounded and just coming back into it, we kind of have a negative deflection for that part. The QRS is generally going to be larger or greater than 0.10 seconds. This is due to the ventricles being stimulated by an impulse originated outside the normal conduction pathway. Let's look at the clinical significance of these different atrial rhythms. A wandering atrial pacemaker is typically not clinically significant. This happens on a regular basis with patients. As a result, your patient may be, and usually is, asymptomatic, and you're only going to pick it up when you do an EKG. However, this could be a precursor or an early indicator of other atrial dysrhythmias, and it could potentially be caused by digitalis toxicity. Clinical significance of premature atrial contractions. Generally, if they're isolated, it's not going to be a problem. Could be corrected by identifying the underlying cause and fixing that. Frequent PACs generally happens more than 6 per minute. Could identify some type of underlying cardiac disease. These may lead to other types of atrial dysrhythmia. So it does, particularly that of atrial fibrillation, which can cause some problems, as we'll talk about in just a moment. And it does bear watching on your patient. Atrial fibrillation, or atrial flutter is related directly to the patient's condition. The ventricular rate is generally well tolerated because it's going to be normal. If the ventricular rate is fast, we may see a decrease in cardiac outload, which does cause your patient to be a little shocky. The treatment is directed to decrease the ventricular rate, either with medication if the patient is stable, or if the patient is unstable, we will use cardioversion. Atrial fibrillation, if it is controlled, generally there's going to be no treatment involved. If we have rapid atrial fibrillation, the treatment is to decrease the ventricular rate with medications if it's stable, or cardiovert if it is unstable. Keep in mind, and this is important, you may see this on an exam, cardioversion of an atrial fib patient does carry the risk of breaking loose a clot that could travel to the lungs, could travel further within the vascular system of the heart, or go to the brain and cause a stroke. So you would want to approach that with great caution. Patients with atrial fib are risk of atrial and systemic emboli due to a decrease in the cardiac output, or the atrial kick. Blood kind of sits up in the atria itself, and as a result of it staying there, generally patients run the risk of having some type of blood clot. That's why we see so many commercials for blood thinning or anticoagulant type medications on television targeted to atrial fibrillation. In the supraventricular tachycardic rhythms may occur patients with healthy hearts and could be tolerated for a very short period of time. Generally, patients are going to complain of a heart running away or racing within their chest. If symptomatic, treatment is directed at slowing the heart rate by use of vagal maneuvers first, drug therapy, or synchronized cardioversion. In the treatment of supraventricular tachycardias, we want to start simple and work up to complex. This completes part 3 of 4 of the atrial rhythms.